Welcome to part 2 of this lecture. Let's begin by discussing Cryptococcus neoformans, which is a fungus provoking diffuse meningoencephalitis. Typical symptoms are headache over several days to weeks, partly but not permanently responding to analgesic medication, subfebrile body temperature, and then from one day to the other, rapid loss of consciousness. From then on, doctors have 8 hours to find the correct diagnosis. In case they don't find it, patients almost obligatorily die. Clinical signs by then are stiff neck and edema of the optic nerve disc, making spinal taps complicated in some severe cases. Imaging procedures, such as a CCT scan sensitive enough, reveal diffuse brain edema. CSF and elevated opening pressure up to 700 millimeters water column and higher, while routine parameters are normal except for a slight lymphocytic pleocytosis in some cases. Diagnosis is made by gram staining of the CSF or by a latex antigen test. Therapeutically, antimycotic drugs like amphotericin B, ancotyl and flucytosine are applied in body weight adapted dosages. Patients are treated until antigen negativity in CSF, determined via spinal tap every 4 weeks, and then followed by a serum antigen titers. Progressive multifocal leukoencephalopathy, or PML, is a demyelinating disease induced by the John Cunningham or JC virus. Affected are oligodendrocytes producing the brain myelin and astrocytes. In healthy individuals, the JC virus is harmless and shed in large amounts in the urine. This virus variant is called the archetype virus and is generally subject to deletions and/or rearrangements in the regulator region of the viral genome before it is found in the brain as a pathological agent. As of 2015, the way the virus chooses to penetrate into the brain and the exact mechanism by which it turns into a highly pathological agent are unknown. The signs are initially subtle, but then moderate to rapidly progressive neurological deficits, such as hemiparesis, hemianopia, hemiataxia, and rapidly progressive mental alterations occur. Characteristic MRI findings are demyelinating lesions which, if untreated, are progressive until a whole hemisphere is affected. The lesions involve the U fibers differentiating PML from HIV-associated dementia and do not or only slightly enhance contrast medium. The JC virus is detected in the CSF by PCR. Routine parameters, including cell count, protein, glucose and lactate, are unremarkable. In case a patient with recently developed symptoms is negative for the JC virus in CSF, but signs and radiological findings are typical for PML, the examination should be repeated after 4 weeks, when there is no rapid clinical progression. If the patient is deteriorating, a brain biopsy should be performed to confirm diagnosis. To date, there are no therapeutic options. Only in CAR therapy-naive patients in whom PML is indicative, first AIDS-defining illness, immediate start of antiretroviral therapy can improve the patient's clinical status. Small trials with alpha interferon, immunoglobulins, foscarnet, cidofovir, and mefloquine failed. There is a report on 4 patients treated with mirtazapine, an antidepressant and JC virus entry inhibitor in astrocytes, which showed improvement but did not meet the criteria for evidence-based medicine. Even if successfully stopped, PML provokes brain atrophy. Clinically, patients remain to be impaired, though often only slightly. Aspergillus fumigatus is a fungus that may result in pneumonia and brain abscesses, which in characteristic MRI findings resemble tennis balls. Clinically, the patients develop deficits according to the abscess localization in the brain. The MRI findings are so characteristic that brain biopsy is only rarely necessary. In case it is, samples must be taken from the center of the lesion to find the infectious agent. There are also infections provoking diffuse meningoencephalitis in HIV/AIDS patients with clinical presentations resembling those of immunocompetent patients. The most frequently occurring are provoked by herpes viruses and Mycobacterium tuberculosis. Herpes simplex meningoencephalitis is a life-threatening disease, especially when diagnosed late. The patients present with headache and fever. The clinical sign is mental alteration. In about 1/3 of the affected patients, temporal lobe symptoms like seizures and aphasia occur, provoked by a local tissue edema followed by necrosis. Finally, patients lose consciousness. From then on, patients must be treated within 8 hours. If not, mortality is as high as 85%. Diagnosis is made by CSF analysis, revealing a lymphocytic pleocytosis of up to 20,000 cells and a protein elevation. Diagnosis is confirmed by a positive PCR for herpes simplex virus. MRI scans show the temporal lobe edema and necrosis, often bilaterally. Patients should be treated with acyclovir 3 times 10 milligrams per kilogram body weight per day for 10 days. Another virus from the herpes group, often resulting in meningoencephalitis, is a herpes zoster virus or VZV. Symptoms and signs are similar to those provoked by herpes simplex virus, except from temporal lobe affection. However, VZV infections are frequently accompanied by vasculitis of small and middle-sized arteries and thus by stroke-like episodes, rarely by a complete infarction of larger vessels like the anterior cerebral artery. Therapy of VZV meningoencephalitis comprises acyclovir and, in case of vasculitis, steroids. The most aggressive virus from the herpes group is cytomegalovirus or CMV. Symptoms of CMV meningoencephalitis are a high degree of fever and rapidly progressive loss of consciousness. Signs are stiff neck and often a vegetative status. Imaging procedures show brain edema and contrast medium enhancement in the ventricular ependyma, typical findings in ventriculitis. CSF reveals, due to the strong bone marrow stimulus, granulocytic pleocytosis of up to 10,000 cells and more, a rare finding in viral meningoencephalitis, usually provoking lymphocytic pleocytosis. The patient's protein content is slightly elevated, while glucose and lactate are normal. Diagnosis is made by PCR, and treatment of choice is ganciclovir, foscarnet, or cidofovir intravenously. However, treatment is often ineffective, so that mortality is high at about 85%. 50% of the surviving patients remain in the vegetative status. In industrialized countries, mycobacterial meningoencephalitis is rare, but occurs frequently in poor resource countries. Symptom onset is subacute over weeks with headache, vomiting, and fever. Clinical presentation is characterized by paralysis of the basal cranial nerves 9 to 12, such as dysphagia and dysarthria. MRI scans show meningeal contrast medium enhancement in case of miliar tuberculosis, microabscesses, and, rarely, calcifying tuberculomas. Diagnosis is made by CSF PCR, CAVE, often falsely negative results. Routine findings are lymphomonocytic pleocytosis due to the chronic cause of more than 10,000 cells, high protein content greater than 1 gram per deciliter, low glucose and elevated lactate. Ziel-Nielsen staining shows a bacterium in like microscope. Classic treatment is a combination of INH, rifampicin, ethambutol and pyrafat. Mycobacterium tuberculosis nowadays is often resistant against this combination, so that streptomycin, rifabutin and clarithromycin are given additionally, or instead of rifampicin, ethambutol and pyrafat. Vitamin B application protects from NIH-induced polyneuropathy. Interactions of the antimycobacterial treatment with CART must be taken into account. CSF should be controlled once a month until normalization. Early diagnosis and treatment make opportunistic infections curable. However, most of them are rare diseases, and thus doctors must be focused on this diagnostic and therapeutic challenge. Thank you for joining me in this lecture, and hopefully you enjoyed it.